Okay, so we move on with the next session, which is pediatric diabetes. As I'm Dr. Manoj Chawla, and co-chairing with me, Dr. Sujata Jali, who's the professor and head of Department of Pediatrics. And the first speaker in this session, we welcome Dr. Aisha Sheikh, who is the Vice President, Sindh Pakistan Endocrine Society, Joint Secretary from 2019 to 21, currently President-elect of Pakistan Endocrine Society. She's been working as a consultant endocrinologist with special interest in antenatal diabetes and endocrinology, and actively involved in research and teaching of both undergrads and postgrads, and has remained endocrinology fellowship program director at the Aga Khan University Hospital from 2015 to 2017. With this, we welcome Dr. Aisha Sheikh.
Bismillahirrahmanirrahim. Assalamu alaikum and a good afternoon. I'm really grateful to Dr. Banshi Sabu and the organizing team for inviting me for this talk for Diabetes India 2022. And I'll be discussing glycemic management of type 1 diabetes pregnancy. I don't have any conflict of interest in terms of content and delivery of this presentation. So my learning objectives are challenges and barriers to achieving good pregnancy outcomes in women with type 1 diabetes, importance of preconception care in women with type 1 diabetes, and glycemic control during pregnancy, intrapartum period, and postpartum period. This is from the IDF Diabetes Atlas 2021. We know that hyperglycemia in pregnancy complicates almost 16.7% of pregnancies globally, while 80% of these are due to gestational diabetes. The rest are either due to pre-existing diabetes or diabetes which is first detected during pregnancy, previously called as overdiabetes or diabetes in pregnancy. So I'll just take you through this patient whom we saw a couple of years ago. She is Mrs. A and was referred to combined maternal diabetes clinic at 9+ weeks of gestation. She is 22 years old, primigravida, and was having type 1 diabetes for last 16 years and was married 6 months ago. She had erratic and follow-ups at the endocrine clinic for last 5 years, was taking Largine 30 units at bedtime and human regular insulin 10 to 12 units before meals. Although she was adherent to diabetic diet but was not regularly exercising, her insulin injection sites were unremarkable, and she brought with her self-monitored blood glucose values, which were done very infrequently, and those showed wide fluctuations, and there was quite significant and frequent hypoglycemias, and she was having nausea and vomiting as well. She did not have any diabetic retinopathy on retinal assessment. Her HbA1c was 8.1%, creatinine was normal, TSH was normal. The urinary albumin to creatinine ratio was a little bit up. She was not having anti-TPO antibodies, and the fetal viability scan showed a viable fetus. So we know that poor glycemic control leads to adverse fetal outcomes in the form of congenital malformations and miscarriages, and this risk increases as the HbA1c continues to go up. So something like 9.3% A1c, there would be a risk of 15% malformations or miscarriages, and this goes exponentially up as the HbA1c continues to go up. So the window of opportunity is actually very narrow in early pregnancy. Right from ovulation, if you look at 3 to 6 weeks post-ovulation, major cardiovascular and CNS defects can occur in the embryo if the embryo is exposed to poor glycemic control at this critical stage of development. And by the time the woman would know that she is pregnant, she would be at this stage, so 3 weeks post-ovulation. And you know that if someone is already entering pregnancy in poor glycemic control, it's very challenging to bring her to control very soon. So this calls upon a preconception control of HbA1c below 7% or even below 6.5% if that can be safely achieved without putting the woman at additional risk of hypoglycemias. And in addition, a good dose of folic acid supplementation at least 3 months prior to pregnancy should be advised. There are lots of challenges in the care of pre-existing type 1 diabetes in pregnancy. These women have already got a lower standardized fertility ratio, and there is a higher risk of operative delivery and maternal ICU admission. However, it is the baby who is bearing most of the brunt of this condition. So there is a greater likelihood of neonatal hypoglycemia, accounting to almost 56 folds higher, and similarly major infant morbidity and mortality, large for gestational age babies and neonatal ICU admissions, almost 5-fold higher than background population. Coming back to the patient, she had cost constraints for doing erratic SMBGs. We had to switch her to analog insulin because she was having frequent hypoglycemias. Her carbohydrate-containing snacks were also given bolus analog insulin. And with frequent SMBG chart review and insulin dose requirements, she was able to bring her to control within 3 weeks after her presentation to the CMD clinic. The repeat ACR, albumin to creatinine ratio, was normal, and her HbA1c dropped from 8.1% to 6.7%. So there are barriers to achieving glycemic targets and optimal pregnancy outcomes. Lack of pregnancy planning is one problem that is significant in our part of the world. Her anomaly scan actually showed intraventricular septum was not clearly visualized, and a possibility of single ventricle was raised. The fetal echocardiography showed a severely hypoplastic right ventricle and transposition of great vessels. And after thorough patient counseling and with a patient and her family, they opted for a termination of pregnancy, which was which took place. So preconception care is actually important in these women. And that should actually start right from puberty, so that these women are aware that they have to plan pregnancy according to when their doctor allows them to do so, and they should be having a good preconception counseling, should know carbohydrate counting, how to manage their diabetes. So they should be powered enough to handle their diabetes so that they're able to achieve a good glycemic control in the preconception period and during pregnancy as well. Similarly, if they are overweight or obese, they should work on towards achieving a decent weight loss near to normal weight control, so that they do not end up having complications because of obesity or overweight. If they are hypertensive, they should be on medications which are safe in pregnancy. And similarly, their thyroid status and thyroid antibody status should be known before pregnancy. And if there are any abnormalities, that should be treated and stabilized before pregnancy. Similarly, CGM or continuous glucose monitoring devices are something which are used nowadays, and wherever the patient can afford, or you can source out these devices for your patients. These are very valuable in terms of managing diabetes in the preconception period and during pregnancy, have shown outcomes which are better compared to just alone SMBGs. Similarly, if they are using insulin pump, they should be familiar with the pump settings and should be able to adjust their insulin requirements coming from increased insulin requirements of pregnancy, should be able to adjust their pump settings accordingly. The long-term microvascular complication should also be screened for, right from neuropathy assessment for nephropathy, and retinopathy. And if there is any retinal disease that is evident in the preconception period, that should be treated and stabilized well before she conceives, because you do not want such kind of retina ending up at such kind of retina, which can happen during pregnancy because of the fact that you are trying to achieve glycemic control very quickly in these women. And similarly, the hormonal changes of pregnancy aggravate the pre-existing retinal disease as well. These are the glycemic goals, and these are the goals which are almost similar to what universally different societies are recommended, something a little bit up or down these goals. This is from the South Asian Federation of Endocrine Societies recommendations. We know that such goals are easier to achieve in the gestational diabetes women or women who have pre-existing type 2 diabetes. But for type 1 diabetes, it becomes quite challenging to achieve these goals. So this is data from 108 women with type 1 diabetes, which showed that these women were at heightened risk of hypoglycemias, mild hypoglycemias occurring almost 5.5 events per patient per week in early pregnancy, which actually decreased throughout pregnancy. But there was a risk of severe hypoglycemia in these women as well. So 45% of women experienced episodes of severe hypoglycemia, which were more marked in the first and second trimester compared to the third trimester. And these hypoglycemias actually led to hypoglycemia unawareness, and that can then result in severe hypoglycemias and led to extra carbohydrate intake and weight gain as well. So this is actually like walking on a tightrope when you're trying to achieve a good glycemic control in a pregnant woman with type 1 diabetes. The other study that was done following this study, the second cohort was the two characteristics of the two cohorts were actually tested, and you can see that for the second cohort, the focused patient education and intervention to prevent hypoglycemia was made. And although HbA1c were comparable in both cohorts as per the pregnancy outcomes in both cohorts, the risk of severe hypoglycemia and hypoglycemia, impaired awareness of hypoglycemia were far less compared to the first cohort. The women in the second cohort used mostly multiple daily insulin. Doses were lower compared to the first cohort, and similarly, most of the women were on insulin analogs and insulin pumps. When you're using continuous glucose monitoring device for your patients, the target glucose range here is 63 to 140 milligram per DL. And this is something that you will set in their CGMs. And you want these ranges more than 70% of the times. They should be, the readings above this should be less than 25% of the times, and readings below this should be less than 4% of the times. And you do not want readings going below 54 to more than 1% of the time. It is important that we should be counseling our patients that even a 5% increase in time in range will increase the benefits for mother and her baby. So suppose she was having a time in range in 50%, and next time she visits in the clinic, she's now 55%. She has already been able to have more benefits because of the fact that her control is better now. So this is a 28-year-old lady with type 1 diabetes for last 25 years. She received preconception counseling and came for the first antenatal visit. She was taking multiple daily insulin with Detamir and Lispro. And you can see that how CGM can demonstrate a change in glucose control when therapy changes. So you can see that in her first visit, her HbA1c is 6.8%, but her sugars are all over the place. You can see that almost 49% of the time she is within target, 48% of the time. And just because of the fact that you have put on CGM and she was able to adjust her insulin doses accordingly, her sugar control is now more smoother, and she is 77% of the time she is within targets. So this is how CGM can help, because she is able to see her readings very frequently and is able to adjust her insulin requirements accordingly and is able to modify her lifestyle as well. The insulins which are saved during pregnancy are actually, for bolus control, you will need either human regular insulin or aspart or Lispro. Either of these can be used depending upon whether affordability is there or not. And similarly, for basal control for background insulin, you will need either NPH insulin or insulin Detamir, or if the patient is already on glargine, that can be continued during pregnancy as well. So you can see that in the first trimester, and this is for somebody who is entering pregnancy in a proper glycemic control. Over here, you can see that the patient is taking almost 50 units per day, and her insulin requirements are actually falling down. And this is what happens in the first trimester in a good and well-controlled women, that hypoglycemia becomes a major concern in first to early second trimester, compounded by the fact that these women have enhanced insulin sensitivity in the first trimester, and the nausea and vomiting, a reduced appetite actually put the woman at risk of hypoglycemia, and that can result in hypoglycemia, unawareness or impaired awareness. So these women actually need a reduction in insulin requirements, and that is something that we need to counsel them, that they have to reduce insulin doses by 10 to 30%, and they have to bolus their analog insulin at least 15 minutes prior to the meal. The fact that they are not at risk of hyperglycemia at this time, which is a critical period of organogenesis, means that the risk to the embryo in terms of embryopathy will not be there. Similarly, in the second trimester, as the pregnancy advances, hyperglycemia becomes a major concern. The fetal pancreas is producing insulin, and so any small out-of-range glucose values in the mom will affect the baby, and there will be hyperinsulinemia and problems of fetal growth and other things that can be associated with high glucose exposure to the baby. We have to check for the quality and quantity of the diet, watch for insulin to carbohydrate ratio. Usually, although basal and bolus both requirements will go up, mostly it's the prandial insulin requirements that goes dramatically up during pregnancy at this stage. And remember that if the patient is taking carbohydrate-containing snacks, those should be bolused as well. And then the interval between meal and insulin should be increased by 20 to 25 minutes over here. In the second trimester, the insulin requirements will continue to go up. So she started with something like 50 units per day requirements and has gone up to almost 100 units per day. And the bolus over here is called a super bolus. So her prandial insulin requirements will go up remarkably. Carbohydrate allocation has to be taken care of, and similarly, she should be having an early dinner because of the fact that progesterones delay gastric emptying. The analog insulin should be bolused at least 30 to 45 minutes or 40 minutes before meals. And the interval between analog insulin and meal is increasing during pregnancy because of the fact that insulin absorption is a little bit delayed during pregnancy. And that is why. So remember that more vigilance is required during first and third trimester. Aspirin, low dose aspirin has a role to prevent preeclampsia, and that should be started before 16 weeks of gestation. Another important thing that we as treating physicians should be counseling our patients that we do not expect hypoglycemias or more than 15% reduction in insulin requirements during mid to late third trimester. If that is occurring, that might be the first sign of placental insufficiency and will warrant post-fetal monitoring and maybe an early delivery as well. Women with type 1 diabetes are at risk of diabetic ketoacidosis, and that can happen even with euglycemia. Almost 10 to 30% of episodes of pregnancy diabetic ketoacidosis can occur with glucose levels which are less than 250 milligram per deciliter. So early recognition to prevent maternal and fetal risk should be there. And similarly, there is a risk of fetal demise after DK, almost 15% within 1 week. So women need to be counseled on prevention. So an emphasis on sick day rules. They should be counseled that they should be testing their urinary or serum ketones if their blood glucose are continuing to stay up above 200 milligram per DL, or if they are having any early features of diabetic ketoacidosis. They should be reporting to their healthcare team earlier on and should be admitted and should be treated accordingly. Intrapartum care, so during labor, you want them to be in a good glycemic control again. The target value during labor is 70 to 126 milligram per DL. And this is needed because this has a direct link with the neonatal hypoglycemia. If the levels are keeping above these values during labor, the risk of neonatal hypoglycemia would be higher. Since glucose infusions would be needed during labor to meet the energy demands of labor, you will need a separate insulin infusion for these women to keep the glucose control within target ranges. Regarding the postpartum care, immediately after birth, the insulin requirements fall rapidly. One needs to discontinue insulin and glucose infusion immediately after birth, keep on testing their blood glucose hourly. And as soon as the blood glucose goes something above 140 to 180 milligram per DL, then subcutaneous insulin should be started. To begin with, it should be something like half the pre-pregnancy dose or maybe 70% the pre-pregnancy dose, and then that dose should be titrated based upon the blood glucose values. During breastfeeding, again, insulin requirements are lower compared to the non-pregnant state. Something like 70 or maybe 50% of dose might be required, but that can be varying from patient to patient and should be individualized based upon their glucose levels that you are having. Similarly, these women with type 1 diabetes are at risk of postpartum thyroiditis. So their TSH should be monitored 6 to 12 weeks postpartum and should be managed accordingly. Contraceptive advice is something that should be given to these women because you do not want them to land up in another pregnancy very soon. And that again, with a poor glycemic control, that should not be happening. So these are my take-home messages. In women with type 1 diabetes, healthy pregnancies can be achieved with right team management, team approach, and medical expertise. Starting at puberty, young women with type 1 diabetes should be counseled on preconception planning. For women planning pregnancy, diabetes care providers should explain the risk of hyperglycemia to mother and the fetus, along with the importance of careful diabetes management throughout periconception period, pregnancy, continuing through labor and delivery and postpartum period as well. Multidisciplinary care to achieve near normal glycemic targets during pregnancy is recommended. So I would like to conclude my presentation by this quotation that to the world you may be just one person, but to one person you may be the world. So you may be that one person who can help her have her bundle of joy in her arms. So I'm really grateful to your patient listening and will be happy to answer any questions at the end of this session. Thank you very much.
Thank you, Dr. Aisha, for beautiful narrating about the pregnancy and type 1 diabetes. Yes, India is again, sadly, the capital of type 1 diabetes, where we have got the highest number in the world. And we do have these problems because 4 patients of mine are also getting married this month itself. So it was a good talk. Thank you. And we will take up the questions at the end of the session. Thank you. Now I call upon Dr. Richard. He's going to give us a talk on management of type 1 diabetes in adults. And he is the Chief Scientific Officer of EASD, Editor-in-Chief of the Journal of Diabetic Medicine, immediate past Chairman, Diabetes UK Council of Healthcare, Professor in Diabetes and Endocrinology within Medicine of Southampton. With this introduction, I welcome Dr. Richard to give his talk. Thank you.
So, Dr. Jali, thank you very much for that kind introduction. I'm afraid you're not quite correct. I'm not the Chief Scientific Officer of the ASD, and I was the Editor-in-Chief of Diabetic Medicine, but thank you anyway for the invitation to be here. So what I was, however, was the European Association for the Study of Diabetes co-chair for the joint type 1 diabetes management in adults consensus report along with the ADA, and that's going to be the topic of my talk for today. So I'll just get my slides up to share. And we will take it away. At least I'll hopefully take it away as soon as we can. So there we go. So as I've just mentioned, I had the pleasure of being the EASD co-chair for the Management of Type 1 Diabetes Consensus Report in Adults. This was published for the first time in October when it was presented at the EASD meeting last year virtually, but it had also been presented in draft at the ADA earlier on in the year. Clearly, it's a pleasure for me to be able to share this consensus report with you, but it's important that I acknowledge that this wasn't work that I did on my own. We had an excellent team of writers from both the EASD and ADA, and I'd like to pay particular tribute to Anne Peters, who was the ADA co-chair alongside me. Before I start, I need to just show you my disclosures of interest, although in reality, none of these had any major role in terms of the development of the consensus report. So I should also mention that at the time when the report was presented at the EASD in October last year, there was then a co-publication both in Diabetologia and Diabetes Care, which provides the full report. And sadly, in a 20-minute presentation, it's not going to be possible for me to go through all of the report and all of the wonderful work that was done in terms of writing the report. So I really would commend you to have a look at this particular report and see how this can be used in order to try to improve the care of people with type 1 diabetes. So just before I go on to describe the report itself, I think it's important that I give a little bit of context to why the report was actually written. And I think we would all agree that in the last decade or so, there has been a tremendous advance, both in terms of the diagnosis and treatment of type 1 diabetes. So when we start to think about some of the new insulins that have become available, some of the new technologies for continuous glucose monitoring, plus lots of other exciting advances, for example, transplantation. But at the same time, despite these advances, we also recognise that there is still a significant burden that's placed on people living with type 1 diabetes. And we also felt that it was important that the management of type 1 diabetes in adults was found in one particular document. So although there are other guidelines around type 1 diabetes, it's often quite difficult to find the information because it's often contained within other documents that have type 2 diabetes. So what we wanted to do was to create a single report where all of the major issues for healthcare professionals looking after people with type 1 diabetes could be found in one particular document. I think it's also perhaps true to say that the EASD and ADA recognised how influential the consensus report on the management of type 2 diabetes has been over the last decade since it was first published, and therefore there was a need to provide and produce a comparable report specifically addressing type 1 diabetes. So this work began in January 2020 when we had our first meeting between the ADA and the EASD writing groups. And our first job was really to decide what we were going to include within the document, and indeed what we couldn't include in the document because of the constraints of space. And as I'll show you on the next slide, there were 17 sections that were identified for inclusion. And our first job was to assign one member from the ADA and one from the EASD to each of these sections to be the primary authors of those particular sections. And that was based on their own interest and expertise. And then within the group, we then reviewed and modified these various different sections and molded them into one article, and then continued to review and modify them with external help where needed, until we had a first draft, which was produced in about January last year. This was then reviewed by 6 external reviewers who were appointed independently by the EASD and ADA. We've made further amendments, and the first public draft was presented at the ADA scientific sessions in June last year, followed by a period of public consultation with further amendments before it was finally approved by both EASD and ADA boards and presented and published at the EASD meeting last year. So here are the 17 sections that were included within the report. As I said, it's impossible in 20 minutes for me to go through all of this report, so I will just be sharing some of the highlights that have occurred within the report. And I'll start off by thinking about the diagnosis. And although this has over many years been done by clinical diagnosis, of course, what we are aware of is that something like 30% of all cases of type 1 diabetes are diagnosed in adulthood, and many of those cases, or a significant number of people who are diagnosed with type 1 diabetes in adulthood, are misdiagnosed as having things like type 2 diabetes, or indeed there may be people who are diagnosed with type 1 diabetes who in fact have other types of diabetes. So this algorithm is based on work that's predominantly been done in white European populations, but probably still has validity in other populations as well. So you start off with a clinical history of type 1 diabetes, and at this point we would recommend measuring the islet cell autoantibodies. And where these are positive, this can confirm the diagnosis of type 1 diabetes. But it is important to recognise that about 10% of people, or up to 10% of people with type 1 diabetes, are in fact antibody negative at the point of diagnosis. And this is a group where we need to have a little bit further thought. Age is probably the next biggest discriminator. So people under the age of 35 are still most likely to have type 1 diabetes, but it's worth considering whether there are features of monogenic diabetes and whether there is importance of looking for genetic testing after testing for C-peptide, or whether there are features of type 2 diabetes. And of course, we recognise an increasing numbers of children and young adults developing type 2 diabetes. For those that are older, 35, the older you become, the more likely the diagnosis is type 2 diabetes rather than type 1 diabetes. And sometimes we need to live with a little bit of uncertainty. And at this point, it's important for us to consider what's the most appropriate treatment at the time. And for some people, even with where there is a suspected diagnosis of type 1 diabetes, it may be appropriate not to start insulin immediately. One of the tests that can then lead on to a more definitive diagnosis, but this is further down the track, is the measurement of C-peptide. And where this is elevated after 3 years, it's unlikely that the diagnosis is type 1 diabetes. So what are we actually aiming to do once the diagnosis has been made? Well, of course, we want to help people to live a long and healthy life. And of course, that then entails a number of different management strategies. So we need to try to maintain glucose levels as close to target as possible in order to prevent the progression of diabetes complications. And of course, that's done with insulin. But at the same time, we need to minimize iatrogenic hypoglycemia, minimize the amount of diabetic ketoacidosis. But of course, as well as prevention, then treating these when they occur. Diabetes management or type 1 diabetes management is not solely around glucose management, and it's important to think about cardiovascular risk factors. And finally, we also need to recognize the psychosocial burden of living with diabetes. And so it's important that with any management strategy, we need to think about maintaining, as far as possible, psychological well-being. So back to glucose, where are we at? Well, of course, the glycemic target needs to be individualized for the individual person, depending on their psychosocial needs and understanding. And of course, we need to recognize that during a life course, this may change. But for most people, an HbA1c target of around 53 millimoles per mole or 7% is appropriate, as long as it can be achieved without significant hypoglycemia. There may be some where we can achieve an even better HbA1c, as long as, again, this can be achieved safely. And there may be some where we need to relax that target, for example, those with limited life expectancy. And I think it's also important to say that although these might be the targets, that when you're talking to people with diabetes, that any reduction in HbA1c from initial high levels is likely to lead to significant benefit. When we're thinking about glucose, we also need to move beyond HbA1c and actually look at capillary glucose measures, but also measures that can be achieved through continuous glucose monitoring. And I'll come on to talk a little bit more about those in a minute. So when somebody is diagnosed with type 1 diabetes, there are a number of things that we need to actually assess right at the start. So we need to provide diabetes education. To tell people about this, we need to prepare them to start glucose monitoring. And as you'll hear, we would recommend moving on to continuous glucose monitoring straight away. But it's still important that people understand how to do capillary blood glucose monitoring in case the technology fails. We need to start insulin therapy, and we can talk about the various different regimens that are available. And I'll come back to that in a minute, while recognizing the problems of both hyper and hypoglycemia. Further down the track, we need to intermittently review whether people are meeting their glucose targets. If they are, that's great. But even those that are achieving adequate glucose levels, it's possible they may still be struggling. And therefore, it's important that we consider whether they need support through education or psychosocial support, but also whether there is a need to think about changes in glucose monitoring or changes in insulin therapy as developments come. Of course, where somebody isn't actually meeting the target, it's even more important to consider that. And here, if somebody's not using glucose monitoring, we would suggest that should take place. Education, said Tony Blair. Well, of course, that's also important for people with type 1 diabetes. And there are a number of times when this is particularly important. So not only at diagnosis, but where people are not making goals, where transitions happen. So you heard about pregnancy in the last talk, and that's obviously clearly important. And also when complications develop. In terms of monitoring, HbA1c is certainly a key measure and needs to be used regularly, but it is important to remember that this doesn't inform everything. Particularly, it doesn't talk about glycemic variability, it doesn't look at hypoglycemia and the risk, and therefore it's inappropriate as the only measure. Traditionally, the alternative measures have been with capillary blood glucose monitoring, and that's still important, but we can recognize, particularly with all the latest research, that even with very frequent blood glucose monitoring, with all the burden that comes with that, there is still a high frequency of undetected highs and lows. And therefore, for that reason, we recommend that now continuous glucose monitoring is a standard for glucose monitoring in people with type 1 diabetes. And I was particularly gratified that in the UK, the NICE and NHS England have actually now recommended that and endorsed this particular recommendation. In terms of the devices available, there's real-time continuous glucose measuring or intermittently flashed glucose monitoring, so things like the Freestyle Libre. And to be honest, the important here is not so much which of these technologies is employed, but the importance of using them in the context of education. In terms of insulins, of course, the best way of delivering insulin is with an insulin pump using hybrid closed-loop technology that provides the greatest flexibility and the lowest risk of hypoglycemia, but sadly it comes at an increased cost. And so therefore we have included within the document the various pros and cons of using insulin analogues versus not, and using multiple daily injections versus pre-mixed, and MDI versus pump. Obviously, this will depend on the costs and the relative, the financial situations of the individual and the health service where they work. But to be honest, I think we would recommend as a minimum multiple daily injections with insulin analogues where that is possible. But of course, really considering the use of pump therapy, because that is associated with the best glycemic outcomes. Within the document, we also talk significant at length, and within each of the different sections, talk about some of the psychological problems that people with type 1 diabetes can occur, ranging from distress, depression, disturbed eating, etc. And therefore, it's important that all members of the diabetes team are aware of these, they know how to provide support and when to refer on. We talk a little bit about the various different adjunctive therapies. In reality, none of these are ideal, and so none of them are recommended, but they may be of benefit for individual patients. There's a section on type 1 diabetes in hospital. This is difficult because, of course, most of the guidance is extrapolated from people with type 2 diabetes, but nevertheless, I think that there is a way forward to try to improve the care of people with type 1 diabetes. And finally, we look into the future, talking about some of the latest developments in terms of both immunotherapy and beta cell replacement. And hopefully by the time we come around to revise it, there'll be yet more information about this particular exciting area. So, ladies and gentlemen, I've given you a whistle-stop tour through the consensus guidance. I can't do it justice in 20 minutes, so please go away and read the full report. It will really help transform the management of people with diabetes. Of course, again, just to reiterate that I couldn't have done this on my own. This is the rest of the writing group. And indeed, we also had support from both the ADA and others from outside. So, ladies and gentlemen, thank you once again for asking me to take part in this year's Diabetes India conference. It's been a pleasure to join you, and I look forward to questions at the end of the session.
Thank you, Dr. Richard, for a wonderful presentation, and we shall take the questions at the end of the session, Doctor. Thank you so much.
Thank you.
Now I call upon Dr. Karen to give a talk on be aware of more forms of diabetes in child. Can I have her introduction slide? Hi, Dr. Karen. Hope you remember me. She is my good friend from SWEET project. And it's my privilege to introduce you, madam. After her MD in Rotterdam, Netherlands, she did the training in Netherlands, Luxembourg, and France, participated in the creation of multidisciplinary team for the adolescent with diabetes in Luxembourg, received several research grants from EU, interregional and national structures, published more than 160 publications in peer-reviewed journals, and she is one of the very active members in SWEET for the publications too. Between 2012 and 16, she was Secretary General, and currently she is the President of International Society for Diabetes, Adolescent and Young Adult Diabetes, that is ISPAD, very well-known society. This is only global scientific society with a focus on all forms of diabetes in young groups through ISPAD. I'm sure that she is preparing for the conference in October in Abu Dhabi. One of the focus areas in her presidency is education and development of e-learning tools to facilitate and improve education in diabetes. With this introduction, May I present Dr. Karen and request her to start her presentation.
Thank you very much for this kind introduction and for the invitation to speak at this symposium. I'd like to first reduce the noise outside. That's always the problem when we've got online.
Can you see the slide? Could you please mention can you see the slides or not? Yes. Dr. Charlie, could you let me know whether you can see the slides? Could you nod when you see them? Can you hear me?
No, ma'am, your voice is so slow.
Okay, can you hear me better like this?
Yes, it's
Yes,
perfect,
we can
ma'am.
hear you now.
Okay, and can you see the slides?
Yes.
Perfect. So then I'll again start in order to share with you some of the experience. And it was, of course, great to have the talk of Professor Holt before on the specificities based on ADA and EASD consensus statement on type 1 diabetes. And I would like to introduce to you some special forms of diabetes you might encounter. But of course, in the past, diabetes was considered one disease. That's one of the very early manuscripts. Although India already very early on differentiated between a type 1 and a type 2 diabetes, looking at those who were having too much food and needed to back off that part, and those who would disappear within a high polyuria and polyuric syndrome. But as time moves on, we now know that diabetes is a group of metabolic diseases characterized by hyperglycemia, which can be based on defects in insulin secretion, action, or both. And of course, I will focus a little bit more on the younger population. And we all know that certainly in that younger population, the chronic hyperglycemia is associated with the long-term damage which needs to be prevented. And as mentioned by the previous speaker, education, not only mentioned by Tony Blair, but as well, I think, by all diabetes care providers. So the classical symptoms, I don't think for this public I have to repeat them. Although, of course, in pediatrics, just be aware, do we really can follow the HbA1c of above 6.5? Some questions still to be addressed. Of course, most often we will be faced in pediatrics with just a clear-cut syndrome, polyuria, polydipsia, weight loss. Although, of course, we would like to see them as early as possible, and maybe even earlier than the weight loss starts. So just a short classification of diabetes in order to make the rest of my talk, partially at least, a little bit more understandable. Of course, the type 1 diabetes, we had a discussion about that just before. The type 2 diabetes, which I think is still limited, certainly when you look in Europe around you, although we must be aware that it is going to increase and is increasing. And today, other forms of diabetes, which I really would like to draw your attention to. Here, ISPAT's clinical practice consensus guidelines can be of help, and do realize these are the ones of 2018. New update is coming freely accessible online from October onwards. And there again, we'll have an update on the classification of diabetes. Now, don't worry, I'm not going to go into all the details of the different monogenic forms, but it's definitely something people need to be aware of. And not only, I think, in the pediatric population, but just as much in the young adult and maybe even older adult population. Maybe there are more hidden monogenic forms which might request a very specific treatment than one is aware of. Again, quite a lot of mutations are known for neonatal diabetes. Some will lead to a passing by form, it's temporary, and others will be associated with a definite diabetes, but sometimes needing insulin, sometimes better treated with oral medication. We need to be aware as well in the genetic field that there can be insulin receptor anomalies or insulin gene itself anomalies. There are syndromes like the congenital generalized lipodystrophia or the short stature associated, the PIK3R1. Again, in pediatrics, cystic fibrosis can be associated, one of the exocrine conditions. And in the past, it was a very limited population which was diagnosed. But now we realize that this population is seen more and more often as well by our adult colleagues because we are aware of it. And we can go for the genetic characterization. Some other forms based on exocrine pancreatic conditions or endocrinopathies, maybe a little bit more rare in pediatrics. We've got the syndrome associated potential genetic conditions like the Turner, which is associated with higher increase, although a lot of children with the Turner syndrome would not have the diabetes, but it can be, and you have to be aware of it. Drug-induced treatment. I think this has been very relevant also to teach us sometimes about pathways leading to hyperglycemia, either temporary or more definite. Quite known, of course, are the glucocorticoids, asparaginase, different forms. Those forms who do not cause any abnormality in the insulin secretion have been associated with less efficacy with respect to their cancer impact. And then growth hormone and beta adrenergic agonists. Infections, congenital rubella, enterovirus, Coxsackie, cytomegalovirus, those are well-known ones. I think the verdict is still out whether type 1, at least, of the coronavirus, SARS-CoV-2, would be a cause as well of diabetes. There are different research projects ongoing, which will help us to clarify, I hope, in the future, what the real impact has been on the incidence and on pathogenesis of type 1 diabetes. And then we've got the very uncommon forms of immune-mediated diabetes with the presence either or not of insulin antibodies, the polyendocrine autoimmune deficiencies, and as well treatment-induced influence of the PD-1 and the PD-1L1 axis. Also, learning something about the pathogenesis of diabetes.
उसके बाद सीधा वहाँ टॉरेंट वाले मेरे को तो 10 मिनट से चल देते वापस.
Excuse me. Can you see the slides?
Yes, sir.
Okay, because there was someone commenting and I can only see slides but don't know what's happening for the rest. So, with respect to the classification of type 1, I just would like to have a little update on the questions we need to ask, whether we are still appropriate by saying there is one type 1 diabetes. I think maybe these recent papers and further research has demonstrated that we should really consider type 1 diabetes not as one single condition. There are maybe different endotypes, and these different endotypes might request different, at least, interventions to prevent progression to insulin deficiency. Should we include, as proposed in the paper by Insel et al., the preclinical stages of diabetes as diabetes? Can we do that? And can we as well try to have interventions for those earlier stages as well? Should we classify and how type 1.5 diabetes? Or is that a different condition? Is this an overlap? Should treatment be as well starting with one and ending with the other one? I think there is a lot of questions which are still open. Just for your, as a reminder, the paper on diabetes care showing the early phases and stages of diabetes and proposing really to consider this already type 1 diabetes. And as well, a little update on how the presence of these autoimmune markers may impact on the progression towards the end stage, hyperglycemia and the request for insulin as treatment. Anyway, many questions, and I'm listing them here without going into them in detail because I should tell you something about the rare cases of diabetes. And of course, all rare cases can't be addressed. So I'm just selecting 3 different ones where I hope that they might be for you interesting in order to consider always with care what diagnosis and what treatment needs to be provided when you're seeing a non-specific case with type 1 diabetes. I think just here as well, 2 further points on type 1 and the different endotypes. I think it is something we really need to consider, even if we try to get, on one hand, clarity on how we should approach treatment and diagnosis. Certainly in the adults, even in the pediatric age group, we need to consider and look out of the box in order to be able to really prevent progression and design a cure. Menogenic diabetes. Just one little update further is really, it is a different kind of treatment. So certainly in pediatrics, essential, or it's often, often a different kind of treatment. So be aware if you've got someone with a diagnosis below the age of 6 months, it is menogenic diabetes until proven differently. If you've got a very strong family history, it's becoming a little bit questionable whether it is menogenic, as we know that there are different families with 3 degree of type 1 classical autoimmune disease. Stronger point, of course, is in any age group after, say, 6 months, 1 year, who have no, for the moment, known autoimmune markers, a diagnosis. High beta cell preservation is as well a sign that you should question what the appropriate diagnosis is. Is it type 1 or is it a monogenic form? And even with the current antibodies, we still have got a population without, even if you test all 5 well-known antibodies. In type 2, certainly in the Caucasian population, that might be different in India because, of course, the risk of developing with limited obesity, type 2 diabetes in the adolescent is more frequent than you would have in the Caucasian population. Same, of course, goes for the African population. If you've got no sign at all of acanthosis nigricans or other markers of the metabolic syndrome. And finally, if you've got a strong family history of diabetes without obesity. And I can tell you that I've had a family of 10, 15 people where 2 adolescents were diagnosed with a MODY. MODY, very simple one, MODY 2, where no treatment is requested. And in 5 adult family members, there was a diagnosis of type 2 diabetes. None of them were obese, maybe an tiny overweight, but nothing more. Caucasian family. And they were all having diet or even an oral treatment. They were all confirmed with a MODY 2. Now, how common is menogenic diabetes? And another question, how good are the data we have? How reliable? How many really representative data we have? Poland had a cohort, white Europeans, and they found between 3 and 4% to 12. Norway, as well, in a younger age group, they were only looking at 0 to 14, and they identified only 1.1%. The USA, multi-ethnic, They were looking at the two cohorts below 20 and below 6 months, found 1.4%, so quite different. But then if you look at the national study, really representative for the full Lithuanian population, which is mainly a Caucasian population as far as I know, they had 100% of the pediatric diabetes population, and they found 7.6% of the entire cohort to have a potential prevalence of monogenic diabetes. So still there as well, there is a lot to be studied and to investigate. We're not yet there. Now, I would like to start this first presentation of a girl, 11 years old, who had a routine medical control, a glucosuria, and then when going a little bit further, she mentioned that there was as well polyuria, polydipsia, headache, weight loss, about 1 kilo. And when we tested further, she had quite a high HbA1c, 11.9, 107 millimolar per mole, normal pH, and hyperglycemia. So first thought, 11-year-old, weight loss, classical symptomatology will be a classical type 1 diabetes. However, you see, no obesity, so type 2 not probable, C-peptide really quite high, and no single insulin antibody. So question, is this a type 1? Probably not. Then going back into her family story, we saw that there were 3 male ones in the family of the father who had a form of diabetes, high HbA1c, insulin treated in the majority, and one with complications, a retinopathy. For us, it was a sign that we had to do genetic analysis, and we identified an insulin gene mutation, which was considered by the Exeter team as being very likely pathogenic. This kind of insulin gene mutation is happening most often in the neonatal phase, although this girl was much older, 11. It's autosomal dominant. We didn't have anything in the father, but we had a positive family history. Another important information is that this specific mutation leads to a misfolded proinsulin, and thus to the retention of proinsulin in the endoplasmatic reticulum, which really makes you consider, how are you going to treat this person? Is the treatment going to be best by insulin or by metformin or another oral drug or not? What is the risk? We considered insufficient data were there to start stimulating the beta cell, because if you increase the presence of that misfolded proinsulin within the cell, that might lead to an increase in the apoptosis of the cell. So we treated with insulin, but you can see this was way far from effective. First of all, there was a massive increase in weight. HbA1c, as you can see, was not at all up to what our objectives and mean values are. And we were talking about a really high insulin dose. Of course, we were frustrated, and the girl definitely as well. So we did some other tries, and so far not yet with the effect we would like to have. The only thing which was surprising is that when she would be very actively physically, that would have a real impact. But an adolescent girl now, 13, 14 years, physical activity is not high on her priority list. Based on her information, we asked the rest of the family to do some further testing. The father had never done any further testing. After, I think, 1 or 2 years and a bit of discussion of one of my colleagues, he did do some testing, and indeed he had as well diabetes with a high HbA1c, and now is treated with the GLP-1 analog and insulin. Grandparents on both sides also seem to be positive based on testing which was done after the girl in our clinic was diagnosed. So here we are stuck, rare form of diabetes. The competition between misfolded insulin and the insulin treatment might give insulin resistance. The injected insulin might have a different effect on the insulin receptor of the adipocyte. We don't know. GLP-1 analog, would we increase the risk for apoptosis based on an increase of intracellular misfolded proinsulin? For the moment, we're working closely together with the Free University, Miriam Knopp, in order to see how we can improve and identify the best possible treatment for the family. The second bit I would like to discuss with you, and just make sure that you're aware of this. I got a phone call from the family where I'm following one of the other kids, not with diabetes, with growth hormone deficiency. And the mum is in kind of a panic because her girl has a diabetes, HbA1c of 7.7, observed and detected by the family doctor, and without any evident symptom. When asking a little bit further, she might drink a little bit more summertime, but nothing else. History of this girl was postnatally surgery for some congenital malformations, and further, she was doing fine. You see, a little bit chubby, 160 with 66 kilos, no consanguinity. Only other thing was that the mother was diagnosed with type 2 diabetes, the brother of the mother was diagnosed with type 2 diabetes, and the grandmother was just diagnosed with type 2 diabetes. No obesity. Two of them were treated theoretically with an oral drug. Although, next step was that the mother told me she wasn't always taking her treatment. Now, if this would be interactive, I would love to ask you this question. What kind of diabetes is this? I guess a lot of people would say D, but I can't ask. I can tell you, I invited the family quickly to come because it was a huge stress. Clinical examination, everything was fine in the girl, doing brilliantly. And we did a lab control in our lab. HbA1c was 5.4. Random glucose was 89. She had no autoimmune markers. She had a completely normal oral glucose tolerance test. So no diabetes, not for her, nor for her mother, or the grandmother, or the brother of the mother. What they had was an abnormal HbA1c. And the mutant of the alpha chain, which is not at all typical for a Caucasian family, was present, and that had, with a specific method of Tosoi, which was used in one of the labs, resulted in high HbA1c. So here, the warning of this rare form of not diabetes, take care, because this is not diabetes, this is an abnormality in the hemoglobin. And as we know, other hemoglobinopathies can lead to these kind of abnormalities and can lead to a wrong diagnosis. Luckily, the grandmother of over 80 just hadn't taken her medication yet, because I quickly, of course, we informed the family doctors. The mother had stopped her medication because she said, I feel always so dizzy if I take this oral medication. So you see, doctor, I stopped it. So very important, if you take HbA1c as only measure, which in pediatrics should never be the case, be aware that different hemoglobinopathies can lead to the wrong diagnosis. The third clinical case, more frequent, I guess, even if it's a rare case, or a confusing case. Maybe that's better wording for this one. This boy participated in a weight-losing program, and he did really a good job. I think he lost 10 kilos. And when the program was stopped, he had 81 kilos, 147. He had acanthosis nigricans. At that time, when he stopped the program, he had a normal HbA1c and a normal OGTT. A year or two later, we got a phone call from the grandmother of this boy. And she said he had done a brilliant job. He had lost weight so well over the last 2 months. But now she was kind of getting a little bit worried because he was drinking more, and she had done a blood sugar level because she herself had diabetes. And the blood sugar was over 360 milligram per deciliter. You can see he had lost 20 kilos. He was tired. And when we did further analysis, before I would again love to ask you this question. I guess a lot of people would think he would have a decompensation of his type 2 diabetes. However, he had ketoacidosis. 25% of up to 25% of newly diagnosed patients with type 2 diabetes can have this, but he had all antibodies positive. So he had classical type 1, but obesity as well. And regretfully, I have to say, he's back to his previous weight, which was around 130. He's now taller than 147, but still he's having a massive overweight or obesity. But he has a classical type 1 together with insulin resistance based on his weight. So diabetes is giving care, and diabetes is always critically considering who you've got in front of you and work together within a team and work together with the patients here in the mountains in Italy. I would like to thank you for your attention and invite you all to the meeting we'll have in Abu Dhabi, not far away from India, in October, where we'll have, I hope, again, a face-to-face meeting for ISPAD. Thank you.
They are most welcome. For Dr. Aisha. Dr. Aisha, what we have been saying is that when they come in first trimester, their A1Cs are in the second trimester. You have experience with the pregnancy outcomes and hyperglycemia. So what is your experience about the pregnancy outcome?
Can you kindly repeat the question because your voice dropped?
You're not able to hear me properly?
Yes,
hello?
It dropped. Yeah, can you repeat? It got interrupted.
Is my voice okay?
Yeah.
Yeah. My question is, what's the outcome of pregnancy if the A1C is high in the first trimester, and then we have a good control in the second trimester?
Yes. So
because of the organogenesis and the congenital in the first trimester.
So what I have seen that if the woman is presenting to their doctors really early, so maybe just they have missed a cycle and have tested their glucose level, tested their pregnancy, and they know that they are pregnant, and they come to us very early and are able to achieve a good control within next 7 to 10 days. So at that time, maybe the burden of disease and the burden of malformations is not that intense. But if she is already reached 6 or 7 weeks of gestation and is poorly controlled, especially if she is not very well empowered to manage her diabetes, and then it takes a longer while for her to get into control. So that is the time where we are actually on the losing front. So earlier, rapid control, the better outcome. Yes.
Okay, thank you. Dr. Richard, I have a problem. Since I'm a pediatrician, the patients do not want to go to the adult diabetologist because they have got a good rapport with me for 10 to 15 years. How do you counsel such patients?
I think that's a really good question. So there is quite a lot of work going on at the moment about how to transition people, pediatric
So find out what's the problem with the voice.
Are you
Neelam,
to hear me?
your voice is breaking, sir.
So I'm not quite sure why that's happening, but I mean, I think that the issue that you raise is the importance of effective transition from pediatric to adult services. And there's quite a lot of work that's been going on to try to work out how to do that best. And I think probably one of the ways to do it is to actually make sure that at least for some of the consultations that you have before that person moves into transition, that they have opportunities to meet the adult team. So having joint consultations across pediatrics and adult teams, so it doesn't feel quite such a big wrench. I think the other thing that's important to consider is that diabetes, that you shouldn't just be fixated on a chronological age. I think we need to be understanding on what's the understanding of that individual and to what extent is that person starting to adopt an adult behaviors around the management of type 1 diabetes and type 2 diabetes. And I think that that's something that can be done over the years that lead up to transition. So one of the initiatives that was actually set up by one of the pediatric nephrologists in Southampton was something called the Ready, Steady, Go initiative, where people are the children actually asked about how they are managing their diabetes, to actually assess their maturity and to find out what the educational gaps there are before they move across to an adult service. I think one of the other things that's also important is that when you move to an adult service, that there are some things that people need to know about that aren't necessarily diabetes related. So, for example, how to navigate health services, and it's important to provide them with education about that. And I think one of the last things that I would suggest is that it's worth having a young adult diabetes clinic where you're just looking after people up to the age of 25 to address these very special needs that occur during emerging adulthood. And I think that can also help. One of the two other things that we've done locally is so we actually have a specialist nurse specifically to look after transitional patients, and we also actually have a social care worker to again help people with those navigational issues, more the social issues of moving care rather than the medical issues. So I hope you were able to hear that okay.
Thank you, Dr. Richard. Dr. Karen, one question for you is, it's a suggestion for the idea of to have in common laboratories to diagnose the other type of type 1 diabetes. And I think in future, India would have a common laboratory. And I know Dr. Mohan is helping us with Modi investigations. But still, this is my suggestion to the Indian IDF, so that we can diagnose other types of diabetes in pediatric too. And I take this opportunity to thank all the three wonderful speakers and for their wonderful talk. And thank you again on behalf of Diabetes India. And thank you for giving me this opportunity. Thank you.
Thank you very much. It's been a pleasure.
Thank you very much. Pleasure to be here.
Thank you.
Is the session ending now?
Yes, sir. I'll hand it over to you, Dr. Sanjay.